Okay, well, thank you very much for this opportunity to present to you for Innovation Challenge Prize number 6. My name's Darby. I'm actually currently employed as a Specialist Projects Lead for the Directorate of Public Health for North East Lincolnshire Care Trust Plus. Right, first of all, fact. If you attend A&E, an emergency care centre, there are usually two outcomes, right? You're going to be admitted or you're going to be sent home. That's it, okay, right? Problem comes actually is that many individuals that attend, right, particularly those who are vulnerable, have complex needs, you know, for a range of services, will actually go because they know where it is, they feel that it's safe there, and they will often go for either an inappropriate or a recurring reason. They don't act on the advice that they're given because at the end of the day, right, if you go in and you're discharged, it will be, we suggest you go to your GP, we suggest you go here, there, whatever. But we know that actually a lot of vulnerable people, particularly 16 to 19-year-olds, don't do that. You know, they will not actually act on the discharge advice. And many of them come back actually usually within 7 days, probably with the same thing that might have exacerbated because it's not been treated, or because of the circumstances that they're in. Why? Well, a lot of them actually, certainly when I was doing this work, when I was scoping this project, right, when I was working with vulnerable 16 to 19-year-olds, they actually had very poor relationships with universal providers like their GP and specialist providers like, for instance, the under-19 substance misuse team, and never actually thought to actually go there in the first instance. A lot of young people as well, I think we have to often assume a knowledge that's not there. And in terms of health literacy in particular, this was a big thing as well. They had very poor levels of health literacy. For instance, when I was actually scoping this, I spent 7 nights in A&E observing who came in, why they came in, right? And there was one lad that came in every night because he was asthmatic. And what he couldn't do was he couldn't manage his inhalers. He didn't know. And I said, have you seen your GP about this? Have you thought about managing this? And he said, I haven't got a GP, don't like them. And I said, well, to be fair, it would probably be the practice nurse you'd be working with anyway. Oh, right. No, didn't know that. You know what I mean? And it's almost like I said, in terms of how they navigate their way through the system, it is very, very difficult, and some of them do not know how to do it. And like I said, sort of, very often, and I always think this is particularly when I used to look at young people in particular who used to come in states of intoxication at night, and they were giving them advice. What advice are they actually going to retain then? How are they going to know what to actually do? I'm sorry, they're pissed. They are not going to be able to do it, so they are unable to actually simulate what advice is given to them. And it's learnt behaviour, to be fair. I mean, health behaviour goes in families, right? Sort of, if you come from a family where there's been a poor relationship with the universal specialist providers, you're just going to carry on that cycle of behaviour. So, when I say health literacy, that's actually what we're talking about, aren't we? Somebody who's a self-directed learner, critical thinker, problem solver, effective communicator, responsible, proactive citizen. When I think about a lot of the clients that Asgard Services I work with, I don't think he's got any of those skills. So what did we do? We looked at an enablement model, actually. I thought, right, okay, we've got a problem here because these kids are being sent home, right, and they're coming straight back because they don't know where else to go. So actually, I need somebody to follow them up after discharge, engage with them and actually do a brief assessment of their needs and make sure they get to where they need to get to. Now, I was actually told, my remit actually when I came to do this was, I was tasked by my Chief Executive and Director of Public Health to look at the needs of vulnerable 16 to 19-year-olds. This is actually where this started. The Asgard model as such has now been mapped out to actually work with different groups. So, for instance, we have a GP practice using this model now. We've been using it for childhood immunisations. And I'm a big believer, particularly in North East Lincolnshire, we have the services. They're there in some parts. People are actually overladen with them. But I always maintain that the problem is people don't get to them, right? The people that need to get there don't get there unless they actually have almost like a hand-holding enablement approach to get there.
We actually as well have done, obviously I did a lot of work with the emergency care centre, which incorporates A&E and GP out of hours. They actually had a problem with this. They said, I don't like sending young people back out into the night. I can't admit them because there's not a reason, but I know full well they're going to be back here in 2 days' time. So it was very much about this strong relationship. If we're going to develop this approach, we need to do it together. Now the aim is actually to proactively follow up a young person within 2 days of admission, 5 days at the outside. It's very much up to the worker and that professional within A&E who is actually referring them to us to actually assess perhaps how urgent the need is. And then basically that's what happens. Like these Asgard workers, Band 4 workers, they will actually meet that young person. They will actually meet them wherever they feel comfortable. They will say, right, okay, this is the 5th time you've been now actually, because, you know, whether it's substance misuse, but, you know, whether it's unsafe sexual practice, whether it's actually just sort of, you know, a lot to do actually with what I called social reasons for admission as well. And it will be, okay, so we now need to get you into the right place where you can get the right service. And actually then, you know, and like I said, and then hopefully your health will improve and you won't need to keep going back there. So who does the work? Now that's Ayers Rock, where I'm going next February. What I always say is that the only crucial thing that an Asgard worker needs, they need to be able to engage with the rock. They need to have absolutely excellent communication skills, be able to engage with non-engagers, and also have an absolutely outstanding knowledge of local services so they know exactly where these young people need to be. Empathy is what they need, communication skills, I said they need to be assertive, have a lot of emotional maturity, because, you know, sort of, and very much as well, because particularly when you're dealing with very vulnerable young people, you need to keep those appropriate boundaries and professional detachment and a good basic awareness of actually what of the health needs of young vulnerable people. So the outcomes, we were set several KPIs. Oh, we're running out of time. Right, okay. We were actually, I mean, this is the most recent data. We were asked to reduce attendance by 120 contacts. Well, we're actually managing now. It's about 233 a quarter. And in terms of re-attendance, this is the ones that were coming back within 7 days of their first admission. Again, we were actually asked to reduce that by 95, but that's coming well. The non-attendance outpatient appointments, because actually as well, that was the other thing. Very often, if young people had attended and say an episode of care had been started, i.e., right, okay, we've sutured you, we need you to come back, you know, we need you to come to an outpatient appointment, you've had a fracture, we need you to see you at a fracture clinic. Well, a lot of these young people weren't coming back, and then they'd come back in a state of crisis with an infected wound or what have you. So that was another big thing, to make sure that episodes of care were actually completed. And that's all to do with the safety of the young people, really. So that like I said, we've managed to increase that. And then again, now these 37 frequent flyers were the ones that I'd identified when I was doing the scoping work, who were actually attending, you know, more than actually, I think it was more than 3 times a month. Some actually, like I've said, were attending maybe 3 or 4 times a week, if not more. And it was very much, like I said, about reducing that. So thank you for your attention. What I'd like you to do now is I'd just like you to read what I've given you, because this is about, we all go on, don't we, about the money. And I'm not saying that the value for money, cost effectiveness isn't important, but I think it's also about trying to keep an idea of what we're about, which I think is care.